Good evening, everyone. I hope you're all warm and safe wherever you are. Welcome to the first KMU webinar this year. I'm seeing everyone is all excited. Happy New Year to everyone as January comes to a close. My name is Dr. Wamboi Kaingithi. I'm the medical advisor at GetZ Pharma, who are the sponsors of this evening's webinar. And this evening, we're tackling everything H. pylori, and we are really honored to have Dr. Siboi to take us through this brilliant topic. And I think with the attendance, I think we can start. So I'll just welcome and give a brief bio about Dr. E. So Dr. Siboi is a distinguished general and laparoscopic surgeon and surgical endoscopist, renowned for his expertise in advanced GI care, minimally invasive techniques, and surgical education. He is currently the head of surgery at MKU, plays a very critical role in mentoring the undergraduate medical students. So Dr. Ray started his journey at UON, which was followed by a postgraduate at Aga Khan University, and he further did his fellowship in diagnostic and interventional GI endoscopy in India. Doc is a very respected leader in the surgical community, holding dual fellowships in the Fellow of American College of Surgeons and COSEXA. And he has also roles in the local society, the Surgical Society of Kenya. He has clinical and research interest, which focus on GI tract, minimal access surgery and metabolic surgery, trauma care, and surgical education. So combining technical excellence, academic rigor, and a dedication to mentorship, Dr. Ari continues to elevate surgical standards and advocating for patient-centered innovation. I think we are very, very honored to actually have this 41-hour session with him. So Doc, without further ado, please take us away.
Thank you very much, Joanne, for that humble introduction. Allow me to share. All right, I believe you can all see my slides. Is that so?
Yes, although now we can see your mood, the mood.
Okay, let me just restart that again. Is that better? There we go. Are you able to see it now?
Give it a minute. Yes, perfect.
Still the same, or has it changed?
It's changed.
It's changed. All right. All right. So just give me a minute and let me just configure that again. Right. I think
Doc, I think now we are good to go.
no, okay. All right. We good? John, I can continue?
Yes, but it's back to the
Okay, there then. That's fine.
okay. All right.
Right.
You're
So
good.
H. pylori, the topic I think we all hear about. All patients come, daktari, I think I have H. pylori, nimeambiwa ni H. pylori. So we'll look at it basically from a pathophysiology point of view, the introduction, the signs and symptoms, clinical tests, and why vonoprazan may be the new kid on the block. So as a disclaimer, I have no conflicts of interest to declare. In the next about 30 minutes, I hope to take you through introduction, prevalence, bit of H. pylori, and NSAID use, pathophysiology, risk factors, symptoms, complications, diagnosis, prevention, management, and what is latest in the evidence that supports the use of the new molecule vonoprazan. So as an introduction, peptic ulcer is a defect in the mucosa with extent to submucosa or deeper layers. An ulcer in the lining of the stomach, we all know, is known as a gastric ulcer, while that within the duodenum is a duodenal ulcer. So these are just images of how ulcers tend to appear on endoscopy. This is a gastric ulcer. This is a duodenal ulcer. And there's common classification when you do endoscopy, the Forest classification for ulcer description. In terms of prevalence, peptic ulcer disease affects about 4 million people worldwide annually and has an estimated life prevalence of 5 to 10%. The low income and middle income countries, as you can see from this image, tend to be in the low income, and the developed countries tend to have a high prevalence. Africa has actually been shown to have almost 70% prevalence for H. pylori. So a bit of microbiology. So Helicobacter pylori is a gram-negative bacteria that causes chronic inflammation in the stomach and duodenum. Helicobacter pylori causes chronic inflammation by invading the lining of the stomach and can cause ulcer formation. For those who are fans of the Matrix, as I am, remember the mechanoids that were trying to catch Neo once he escaped the Matrix and find Zion? That's how I remember H. pylori. Looks like those mechanoids with tentacles. So it invades by damaging the protective mucus layer. And once the mucus layer is damaged, acid then erodes the underlying layers of the stomach, forming an ulcer. The other common mechanism by which ulcers are formed are persistent use of non-steroidal anti-inflammatory drugs, including aspirin, brufen, and naproxen. In biosimilar mechanisms, so blocks formation of prostaglandins, which are known to protect the gastric lining. So you inhibit formation of prostaglandins, you get decreased mucus secretion, decreased bicarbonate secretion, and decreased blood flow, all of which result in mucosal damage, epithelial injury, and eventually ulceration, especially by the corrosive nature of the foods we eat. As for the pathophysiology, the lining of the stomach is a layer of special cells and mucus. The mucus prevents the stomach and duodenum from being damaged by acid and digestive enzymes. If there's a break in the lining, such as an ulcer, the tissue underlying can then be damaged. If the ulcer is deep, it can cause serious pain, it can cause bleeding, and can eventually cause a perforation. Several factors have been associated with an increased risk of developing peptic ulcers, such as smoking, which is especially so if you're infected with Helicobacter pylori, excessive use of alcohol, and genetic factors. However, contrary to popular belief, stress and spicy foods do not seem to increase the risk of ulcers, but you can have stress gastritis. So smoking has been shown to be an independent risk factor for symptomatic and asymptomatic peptic ulcer disease. This risk progressively increases with increasing pack years of cigarette smoking. There's a population-based study that found the prevalence of ulcer disease in current and former smokers was almost twice as high as in non-smokers. So it has been seen that smoking more than 15 cigarettes per day compared with never smoking increased the risk of a perforated ulcer more than threefold. However, in patients with H. pylori, smoking does not appear to be a risk factor for ulcer relapse once H. pylori has been eradicated. In terms of alcohol, high concentration damages the mucosal barrier, and it's related to development of complicated and uncomplicated ulcer disease. Another large population-based study showed that heavy drinking, that is about 42 drinks per week, increased the risk of bleeding ulcer fourfold. Relative risk was 4.4 with a 95% confident interval compared to drinking less with 1 drink per week. In terms of genetic factors, host factors appear to be important in predisposition for H. pylori, especially the pro-inflammatory cytokines and anti-inflammatory cytokines associated with peptic ulcer disease. There's also evidence for a genetic predisposition to peptic ulcer disease that is independent of any predisposition to H. pylori. In terms of symptoms, 70% of patients with peptic ulcers are asymptomatic. These patients with silent peptic ulcer may later present with ulcer-related complications such as hemorrhage or perforation. Between 40 and 80% of patients with bleeding ulcers present without antecedent dyspepsia or any other GI symptom. For those who tend to be symptomatic, the most common symptom is a burning or gnawing pain in the upper abdomen. And endoscopically, approximately 80% of patients will be seen to have an ulcer if they have these symptoms. Next common, the other associated symptoms include bloating, abdominal fullness, nausea, early satiety, pain provoked by either eating, which is significant for gastric ulcer, or on an empty stomach, which points more towards a duodenal ulcer. In terms of complications, and where mostly the surgeon comes in, though endoscopy is also taking a big role in, we have bleeding, perforation, penetration of fistula formation, and obstruction, commonly gastric outlet obstruction due to scarring and stricture formation. In terms of diagnosis, what are the common differentials we think about when thinking about peptic ulcer disease or other causes of dyspepsia? Number one of your list should be drug-induced. Think about biliary disease, cholelithiasis. The back of your mind always have possibility of a gastric or a duodenal malignancy, and less commonly chronic pancreatitis. Most of these conditions can be excluded from peptic ulcer disease by an upper endoscopy. Another non-invasive test to detect the bacteria is a urease breath test, not commonly available in the country though, whereby you swallow a substance containing carbon. If H. pylori are present in your stomach, you will have a positive breath test. Upper endoscopy. So stool test, stool antigen test, not antibody test, is a test more specific than blood antibody test in terms of detection of Helicobacter pylori. However, if you do not have symptoms, it will not warrant treatment. And even after treatment, it takes a while before you get a negative stool antigen test. So I commonly see patients who keep being given kit after kit after kit based on positive stool antigen test. So you also just need to follow up your patient and assess symptomatology in terms of treatment and management. In terms of invasive tests, endoscopy is the most accurate diagnostic test for peptic ulcer. The sensitivity of upper endoscopy in the detection of gastroduodenal lesions is approximately 90%. However, this varies with the user and the location of the ulcer. So during endoscopy, there are certain indications to biopsy an ulcer if seen. Either we are suspecting a malignancy, whereby you have an ulcerated mass protruding into the lumen. The folds surrounding the ulcer crater tend to be nodular, clubbed, fused, or stop short of the ulcer margin, or you have an overhanging, irregular, or thickened ulcer margin. For those that appear benign, the ulcer tends to be smooth, irregular, round-edged, with flat, smooth ulcer base. However, to get tissue for histological examination for H. pylori, usually the recommendation is 6-point biopsy of any gastric lesion so that you send it out to the pathologist. Towards the end, I will also talk a bit about the association of presence of H. pylori and gastric malignancies. In terms of prevention, which is primary healthcare, H. pylori is extremely common, especially in the African setup. Probably person-to-person spread and crowded living spaces appear to be risk factors. So we need to also emphasize good hygiene to our patients, including hand washing thoroughly before eating and after using the washroom. Recurrent ulcers from H. pylori can usually be prevented with appropriate treatment. So I highlight that in terms of appropriate treatment because there are times you find a patient was suboptimally treated in terms of the duration. Also advise patient to limit the use of NSAIDs for pain. However, if they have to use NSAIDs or low-dose aspirin, they need to be covered with a low-dose PCAB or PPI. In terms of management, there are different modalities. Initially, we'll start with lifestyle modification. More so in patients who have also symptoms of reflux disease, so elevation of the head of the bed, avoiding meals at least 3 to 4 hours before bedtime. And for those who are obese, we advise them on weight loss because most of the times the symptoms that are presenting are symptoms of dyspepsia. With confirmed presence of Helicobacter pylori, then you would initiate triple therapy or H. pylori eradication therapy. And there are guidelines that are out there by the American Society of Gastroenterologists that highlight to us the combinations of medication that we can use. But initially with dyspepsia, you'd want to try medical therapy, including antacids, proton pump inhibitors, H2 receptor antagonists, though these seem to have fallen out of favor, prokinetics, and or baclofen. In terms of surgical intervention, this comes in when you have failed medical therapy or when you have complications of peptic ulcer disease. So some of the procedures that we can offer patients include tracheal vagotomy for recurrent peptic ulcer disease, highly selective vagotomy. If it is a ulcer that has malignant transformation, then you would have to do an antrectomy, so resection of the stomach, and a drainage procedure. If endoscopy is unable to control bleeding and a patient rebleeds, so a double setup is usually advocated for, whereby we attempt endoscopic control of the bleeding, and if that fails, we proceed to surgical intervention. In terms of antacids, again, you see quite a number of patients who come to you and they're simply on antacids. So how basically it has an immediate effect on gastric pH. However, this effect is short-lived. You get only symptomatic relief, and it has a less established role in terms of ulcer healing. Also, persistent use of antacids will give you a diarrhea. H2 receptor antagonists are via competitive inhibition, inhibit H2 receptors, thereby partially inhibiting acid production and offering symptomatic relief. However, they are again less effective than proton pump inhibitors. Proton pump inhibitors increase the gastric pH to above 5 for several hours, covalently binding to the hydrogen-potassium pump. It is a potent acid inhibitor and offers symptomatic relief and proven and best ulcer healing rates. So most times this is a simple algorithm that you can use in your practice. So a patient comes with non-specific symptoms consistent with functional dyspepsia, epigastric discomfort, bloating, belching, early satiety. However, as long as they don't have any alarm signs, then you can proceed to either test for Helicobacter pylori, urease breath test, or via biopsy or stool antigen. If it is H. pylori positive, then you have to institute eradication therapy. So if there's epigastric pain syndrome, also additionally add an acid suppressive agent as a first line and a prokinetic as a second line. For those who have postprandial distress syndrome, initiate a prokinetic, and if that doesn't offer enough therapy, an acid suppressive agent. If this as a second line doesn't offer relief to your patient, consider this patient therapy resistant. And probably at this point, you're thinking, am I referring to a specialist? Because at this point, then you have to think about neuromodulation and additive therapy, such as phytotherapy, cognitive therapy, acupuncture, or hypnotherapy. So as per the guidelines, H. pylori eradication therapy, what has been known has been the standard triple therapy, where you have a PPI and 2 antibiotics for at least 7 to 14 days. What I would say in my practice, I would recommend 14 days. The short course treatment of 7 days, more often than not, leads to recurrence, especially in our setup whereby you find that by the time the patient seeks help, they have been to the pharmacy and they have already had a course or a short course of antibiotics. Bismuth quadruple therapy has actually risen to be one of the first-line therapies that is recommended. So giving a PPI twice daily, bismuth salt between 120 to 600 milligrams in divided doses, metronidazole and tetracycline. However, the pill burden becomes high because tetracycline is given 4 times a day, and most patients tend to then be non-compliant. You can also offer sequential therapy whereby you break it down. You give a PPI with an initial antibiotic for the initial 5 to 7 days, then followed up with a PPI and a different set of antibiotics, which is a triple therapy, for an additional 7 days. You also have hybrid therapy, or if your patient is having side effects from clarithromycin, you can move to a levofloxacin-based therapy, either as triple therapy or as sequential therapy. The guidelines, again, which are mostly based in the US, talk about rifabutin, but as we know in our setup, it is used in the treatment of tuberculosis. So we tend to shy away from the use of rifabutin in terms of use for H. pylori eradication. So where are we now in terms of innovation and to meet our unmet needs in terms of the patients who are not responding to your standard PPI? So historically, H2 antagonists were introduced in the 70s. Then came in the PPIs, which have been around for the last 30 years, 25 to 30 years. And more recently, well, now almost 10 years ago, introduction of the potassium competitive acid blockers. So vonoprazan fumarate is a first-in-class potassium competitive acid blocker that has been in existence since 2015. It has been shown to inhibit the hydrogen potassium ATPase in a reversible and potassium competitive manner, with a potency of inhibition approximately 350 times higher than your standard PPI lansoprazole. So vonoprazan is an acid-resistant pyrrole derivative developed by Takeda Pharmaceutical Company. So it's a competitive enzyme inhibitor. It has a long plasma half-life, stable in an acidic environment, high accumulation within the canaliculi with a very slow dissociation rate, and it is primarily metabolized by CYP3A4-5. Combination of all this result in a rapid onset of action, potent acid control, and durable 24-hour activity with a 20 milligram dose. So comparative studies, if you compare the standard dose of 20 milligram omeprazole, 20 and 40 milligram, lansoprazole 30, rabeprazole 20, revaprazan 200 milligrams, and then you have the vonoprazan 10 and 20 milligram tablets. So focus on the last column. So you're looking at the half-life of these doses. The standard omeprazole, you have 1.3 to 1.6 hours. Omeprazole, 0.5 to 1.2 hours. And if you focus down here on vonoprazan, you're looking at half-life of 6.95, 6.85, 6.95 hours. In terms of proposed treatment algorithm, so the authors propose a new strategy of H. pylori eradication treatment, amoxicillin, clarithromycin, and potassium competitive acid blockers. Triple therapy is sufficient treatment. Even for those with clarithromycin resistant strains, use of amoxicillin, metronidazole, and a PCAB or a PPI triple therapy with a quinolone-containing therapy or bismuth quadruple therapy may be recommended as rescue therapy. So CAM here is a clarithromycin resistance. So this was published in the Journal of Neurogastroenterology and Motility in 2019. So basically, if you're talking about triple therapy, again, you can use amoxicillin, clarithromycin, or PCAB in your triple therapy. Or you can use as a first line amoxicillin, metronidazole, and either a PPI or a PCAB. So we are simply saying that vonoprazan is non-inferior or equipotent to a proton pump inhibitor. Or for quadruple therapy, whereby bismuth is used, you can also replace PPI with a PCAB. In terms of rescue eradication therapy, either bismuth quadruple therapy or quinolone-containing quadruple therapy. So this is for H. pylori eradication, which is the first 2 weeks. Subsequent to that, you need to continue your patient as the mucosa regenerates on a PCAB or a PPI for at least 4 to 6 weeks based on their symptomatology. So in my practice again, and if you look at what is out there in literature, you can give a PCAB OD dose of 20 milligrams for at least 4 weeks to 6 weeks after the initial eradication therapy for H. pylori, rather than just giving antibiotics and giving your patient a short course of PCAB or PPI. H. pylori and gastric cancer. So as a gastric pathogen that colonizes approximately 50% of the world population, infection with H. pylori causes a chronic inflammation and significantly increases risk of both duodenal and gastric ulcer disease and gastric cancer. Infection with H. pylori has been shown to be the strongest risk factor for gastric cancer, which is the second leading cause of cancer-related deaths worldwide. Once H. pylori colonizes the gastric environment, it persists for the lifetime of the host, suggesting that the host immune response is ineffective in clearing this bacterium. So there have been many studies out there that have provided consistent evidence that chronic H. pylori infection is associated or causes gastric adenocarcinoma and gastric malt lymphoma. So epidemiological studies in as far as gastric adenocarcinoma is concerned have shown that people with chronic Helicobacter pylori infection have an increased risk of developing non-cardiac gastric adenocarcinoma. Similar epidemiological studies have also shown that in geographic areas where stomach cancer is common, especially in Asia, people with chronic H. pylori infections have an increased risk of developing gastric cardiac cancer. So that is a part of the stomach that is closest to the esophagus. In addition, there are other studies that have shown that treatment to eradicate H. pylori infection reduces the risk of gastric cancer in asymptomatic individuals, in individuals at increased risk due to family history, and in those who have had surgery for early gastric cancer. In terms of MALT, gastric malt lymphoma, nearly all patients have shown signs of H. pylori infection. When people with so the strongest evidence linking H. pylori infection with gastric malt arises from studies showing that when people with gastric malt are treated with antibiotics to eliminate H. pylori, their tumors tend to shrink. So what is the evidence for the use of the new kid on the block, the PCABs? So vonoprazan has demonstrated eradication rates of greater than 90% in dual therapy with amoxicillin only. So number one, you reduce the pill burden to your patient and you're not disadvantaging your patient in terms of therapy. So when you compare dual and triple therapy, healing rates are almost similar. So studies out there, there's this one published that shows the efficacy and safety of vonoprazan-based treatment for H. pylori. So the results of the RCTs were collected from earlier available studies in August 2023. 21 randomized controlled trials were included with a total sample size of almost 5,480 patients. The results of this network meta-analysis showed that eradication using vonoprazan-based quadruple therapy for 14 days in an intention to treat analysis were well tolerated, giving the conclusion that compared with traditional proton pump inhibitor-based therapy, vonoprazan-based therapy have shown superior eradication effects. Their final recommendation was a 14-day quadruple therapy with bismuth-based vonoprazan. Xiangpeng and colleagues, looking at efficacy and safety of vonoprazan and amoxicillin, similarly looked at about 623 patients, of which 516 were randomized in intention to treat and per protocol analysis, and eradication was compared. So overall, vonoprazan-based therapy was non-inferior to standard treatment. So the conclusion again was both the 10-day and the 14-day regimen of vonoprazan combined with high-dose amoxicillin are effective and safe options for initial H. pylori eradication. Last study that I'll mention is the vonoprazan amoxicillin combination therapy for Helicobacter pylori. This is from Egypt, published in the Egypt Journal of Internal Medicine, whereby they looked at articles and they scanned through 13,700 articles, and 4 meta-analyses were included. There was a significant overlap noted in the studies. However, their eventual conclusion, again, was that vonoprazan amoxicillin combination is effective in eradication of Helicobacter pylori with limited adverse side effects. That said, to summarize it all, Helicobacter pylori is a common problem because it is a master at survival and a leading cause of ulcer, and more so a significant cancer risk factor. Therefore, eradication is crucial in symptomatic cases, but rising antibiotic resistance demands careful treatment strategy. And vonoprazan in combination therapy for eradication of Helicobacter pylori is effective. We'll take questions towards the end or in the question and answer box. And that concludes my presentation today. Thank you very much for your attendance. Over to you, Joanne.
Thank you, Doc. Thank you. So if you have any questions, just a reminder, please type them in at the Q&A section. We'll read them out. I'll give Nelly an opportunity to just brief us about our GetZ product portfolio. Welcome, Nelly.
Yes, sorry, I'd forgotten to unmute. So I hope my screen is visible.
Yes, it is.
Yeah, so my name is Nelly Anzazi from GetZ Pharma. I'm a product manager there. And, as I was listening to Dr. Siboy's presentation, I was busy questioning myself. It's an evening, everybody's tired. So what do I want our doctors to walk away here from me? What is the take home message that I want them to go with? So basically the reason, the key things that I like to highlight is, first of all, to introduce our company, which is GetZ Pharma. So for those who do not know, GetZ Pharma is headquartered in Pakistan, Karachi, and we manufacture our own drugs. We have not, the production is not subcontracted, especially for Vonapro. So we pride ourselves on quality brands across Kenya and other parts of the world. So for tonight's session on the topic of revolutionizing H. pylori treatment, the key focus is this new therapeutic class in gut management, H. pylori management, that is the PCABs. And for now, as Dr. Siboy had highlighted, the PCAB that is currently available in the market is vonoprazan. That's the molecule name. And GetZ Pharma, I'm proud to say that we have our brand of vonoprazan that goes by the brand name Vonapro. It comes in 2 SKUs, the 10 and the 20 milligram. So hopefully, at least maybe you've come across it wherever you're practicing. And if not, I'd like to appeal that whenever you're thinking of a pickup to use on your patients, maybe they're not responding on the PPIs that you've been giving, or the acid suppression is not sufficient, or you want an alternative to H. pylori eradication, when you think of pickup, kindly think Vonapro 10 and 20 milligram. So I think this slide, Dr. Siboy has already gone through it, which basically highlights the mode of action. And just to echo is that it inhibits the hydrogen potassium ATPase activities in a reversible and potassium competitive manner. And it has a higher potency, very high potency of approximately 350 times higher than the PPIs. That is the esomeprazole, the lansoprazole. The inhibition is quite high at over 350 times. All right. And as I'd mentioned, there are only 2 SKUs available. So we have the Vonapro 10 milligram and the 20 milligram in the market. So for the indications, there's in the treatment of gastric ulcers, duodenal ulcers, and the treatment regimens are 8 weeks for gastric ulcers. For duodenal ulcers, is 6 weeks. All right. And the 2 SKUs, that is, okay, for the gastric and duodenal ulcers, it's only the 20 milligram that is given, right, once daily for the treatment of the ulcers. And then at 20 and 10 milligram once daily for 4 to 8 weeks for the treatment and secondary prevention of reflux esophagitis. All right. And then we have the 10 milligram that is also administered daily for secondary prevention of low dose aspirin or NSAID drug-induced peptic ulcers. So for the patients that maybe you've administered NSAIDs and they are at risk of maybe experiencing, gastritis, peptic ulcers due to the NSAIDs, the 10 milligram is always recommended for prevention reasons. And then we have the 20 milligram, that is the strength that is used in the eradication of H. pylori. And the good news about vonoprazan, our Vonapro, is that in eradication of H. pylori, it can be used both as a dual, in dual therapy or triple therapy. So for the triple therapy, as you all know, you always have the PPI. So in place of the PPI, you give the Vonapro 20, and when you in cases of macrolide resistance, which is a common problem, especially in our population, many patients maybe are resistant to clarithromycin. You can just give it with amoxicillin. So it's given 20 milligram plus amoxicillin in the morning. And then in the afternoon, the patient takes the amoxicillin alone. And then in the evening, they take the 20 milligram plus amoxicillin again, all right, for 7 days. Yeah, so this is just a brief summary of whatever that has been talked about on the clinical superiority over PPIs. So as I go down, there are graphs here that just essentially elaborate the superiority of Vonapro over PPIs. So when it comes to the clinical evidence with regard to H. pylori eradication, the graph that is displayed there, this is a study that Doc has just highlighted briefly. So in case anybody wants, because we don't have a lot of time to go through each and every detail, so I can see so many emails. So I'll try as much as possible to at least forward these studies to you. So at least you can read them during your own time as you try and embrace this new molecule in the market in the eradication of H. pylori. So in this slide is that patients that were given vonoprazan, that is Vonapro 20 milligram, in comparison to those that were on a PPI, the efficacy was higher in patients that were on vonoprazan compared to those on lansoprazole, that is the PPI that was used in this study. All right, and even patients with clarithromycin resistant H. pylori, the efficacy and eradication of H. pylori on the patients that were on Vonapro was better compared to those that were on lansoprazole. This is just a continuous comparison on the efficacy of vonoprazan compared to PPI in triple therapy and the efficacy, and you can see that the efficacy of vonoprazan is quite better compared to the PPIs. And on the right, there's a comparison of vonoprazan dual therapy versus vonoprazan triple therapy. So you can see the efficacy is more or less the same. That is when you administer it as a dual therapy or a triple therapy. The efficacy in eradication of H. pylori is more or less the same. Okay, so this is basically the Vonapro 20 that is in use here, not the 10. And then on the clinical evidence for pH sustenance above 4. Those are graphs that also elaborate the same. We have all studies on this as well. So those who are interested, I'll still forward them to you guys. And Doc had mentioned that vonoprazan is not acid dependent. So there's the meal time flexibility that is compared to PPIs, conventional PPIs that are currently in the market, where a mealtime food has an effect on the efficacy. When it comes to vonoprazan, the efficacy upon administration and fasting and after meal was more or less the same as is depicted on the graph that is showing right now. And also, this is also an evidence on the clinical evidence on eradication of erosive esophagitis. Still, Vonapro reigns superior compared to the PPIs that were used. And even in terms of heartburn relief during the day and at night, Vonapro still reigns superior. And there are studies to, substantiate all this. So we can still share those, so you can go through the studies in detail in your own at your own time. So that's basically a summary of the clinical superiority of Vonapro over PPIs. And when it comes to the safety and tolerability, the side effects are more or less the same just as the PPIs, the diarrhea, the constipation, the nausea, the rash. But again, as our medical advisor always tells us, whenever the benefits outweigh the risks, you are the doctor's experience, so definitely the judgment will be based on your patients as well. So the benefits of Vonapro being way better, more compared to PPI, I think, okay, from a marketing perspective, I'd say pick Vonapro, definitely, because I'm a marketer at the end of the day. Yeah, so when it comes to special population consideration, of course, with the studies that are there, is that care has to be observed whenever you're administering Vonapro, to patients who have renal, hepatic disease. So care should be observed because there are no studies to elaborate the safety when vonoprazan is administered to this type of patients or kind of population. For elderly patients also, care should also be observed. And there are no studies to support administration of vonoprazan for patients under the age of 12. For pregnancy and lactation, there are also no studies to elaborate the safety of vonoprazan. And there are also minimal drug-to-drug interaction whenever patients are on vonoprazan compared to those on PPIs. So that is just a summary. This is just a summary of what I've been talking about as well. Yes. So basically, again, to emphasize, the molecule is vonoprazan, but the brand from GetZ Pharma is Vonapro, 10 and 20 milligram. Before I finish, I'd also like to highlight a few of our brands that are new in the market, and I'm sure maybe already interacting with. So currently, I think most of you have come across our statins range. We had the atorvastatin and the rosuvastatin. So we've introduced our Rovista EZ, that is rosuvastatin plus ezetimibe, Rovista EZ. We also have our MPGate range for the diabetic patient. I think for the longest time, you've had the MPGate plain 10 and 25. So we recently also introduced the MPGate LT into the market. And for your heart failure patients, we also have a combination of sacubitril plus valsartan, and the brand is Vacutro, 50, 100 and 200. They're all there, the SKUs. And in as much as I've talked so much about PPIs, let me just not forget that we also have PPIs with us and our portfolio. We have our esomeprazole that goes by the brand name Esom, and we have the entire range. We even have the IV. So yeah, vonoprazan is there, but you still use the PPIs are still in use. So whenever you also choose to use a PPI, we have our esomeprazole, Esom, 20 milligram and 40 milligram, and also the IV option. Yes, so basically that's it. I'd like to end it there. Yes, so with
Thank
special
you.
emphasis on Vonapro as your vonoprazan of choice for your patients who have H. pylori and GAD in general. Thank you so much.
Thank you, Nelly. Maybe just confirm, highlight on the pricing. You think you've missed that?
Yes, so for the price, the 10 milligram goes for 67 bob per tab, while the 20 milligram goes for 75 Kenya shillings per tab. But that is dependent on where the patient is going to purchase.
All right, thank you.
Yeah.
I'm seeing, Doc, we've lost, he's dropped off. Let's just give him a minute. So as we wait for Daktari, there's a question that highlighted, was asking if vonoprazan is superior in terms of the in relation to the standard PPI. Definitely from Dr. Siboy's and Nelly's presentation, I think that we've answered. Doc, are you back? Yes, great.
Sorry for
Okay.
that, yeah.
All right, so I think we have a number of questions. I'll try to summarize and see how we can work around it. So maybe the
Okay.
first question is, how do you choose which patient to undergo non-invasive investigations versus invasive investigations while you're working them up?
Obviously, rule of thumb is if you have the non-invasive investigation, that would be the optimal one to start with. But I've said, as I've said, the urease breath test is not easily available. So most times you end up, at least as a baseline, you do a stool antigen test. But if you had the urease breath test, that is what you would offer. Patients who've had quote unquote repeated treatment for H. pylori, I would recommend you send them over for an upper endoscopy and a biopsy, and we let the pathologist tell us whether the H. pylori is actually there or not. More often than not, you find they just have chronic gastritis and H. pylori negative, or more often than not, you may also find that they either have an unrelated or rather a different disease process, either reflux or cholelithiasis.
Thank you, Doc, for that. The other question is, in the NSAID being one of the causes of PUD, does topical NSAID also predispose a patient to getting peptic ulcer disease? And is there a relation between PUD and CAT, MIRA?
So in terms of topical NSAID, mechanism is the same, how it controls pain. So the short answer is yes. Even topical analgesia, especially for back pain, will eventually or can eventually predispose you to peptic ulcer disease. Relationship between CAT and gastritis is there because most times you're chewing and on an empty stomach. So just the simple pathophysiology of how you change the environment in the stomach can predispose you to formation of ulcers.
Thank you, Doc. Then,
Yeah, but no studies out there. So maybe that would be an interesting study, especially in the areas where cat is commonly chewed, to assess who have symptoms and probably even look at diagnostic endoscopies in that population to just see the changes within the stomach. Yeah.
Thank you.
Yeah.
Then, so going back to testing for H. pylori,
Yes.
the MO, we are now outpatient setting and we end up doing the H. pylori stool antigen. Then we see it's positive. So do we still treat, first of all, do we still treat maybe that it could be a false positive? Or if a patient is asymptomatic, will we still initiate treatment if it's just an incidental finding?
Again, this goes back down to our history and physical examination. What symptoms triggered you, or what physical examination signs triggered you to request Helicobacter pylori stool antigen test? if you're doing it just as a matter of routine and your patient has no symptoms, really there's no indication to initiate triple therapy. However, if they have symptoms consistent with basically dyspepsia or symptoms consistent with peptic ulcer disease, you can initiate the triple therapy. But for me, what I would recommend just practically, initially give your patient maybe 2 or 3 days of acid suppression only, be it an antacid or a PCAB or a PPI, and see how they respond. If they improve, you just clinically follow them up. However, if the symptoms still persist, I would then initiate eradication therapy.
Thank you, Doc. So you've started the treatment. The question is, after the 14 or 10-day treatment,
Yes.
if your patient is on PCAB, should you still give them PCABs for the next 4 weeks, the way the practice has been for PPI? Is it still recommended also to just give the PPIs? If the patient is using PPIs, should they still be on PPIs for the next 4 weeks after the treatment?
I would say yes. I mean, we don't have any long-term studies in terms of the duration, but based on the studies that have shown it is almost 350 times more efficient than lansoprazole, the answer would be yes, give it for the same duration, at least 4 weeks, and then assess how your patient does. So you can even actually taper down. You can start at the dose of 20, maybe for 2 weeks, and then probably go down to 10 milligrams and see how your patient responds. Because remember, the whole aim is you want to give the gastric mucosa enough time to regenerate after eradication. Yeah.
Thank you, Doc. Is there a role for probiotics in management of H. pylori treatment?
No evidence to suggest any role for probiotics, honestly, but it is given simply because of you're putting your patient on dual antibiotics. And, what is well known is that you would then also eradicate the good bacteria. Yeah. So no long-term studies again also or looked at whether it is just placebo or not. But if you just think about the logic that you're giving your patient antibiotics continuously for 2 weeks, there is no harm in adding a probiotic just to sort out to replenish the normal flora for your patient. Again, the other thing you need to think about is the pill burden to your patient. So maybe treat the ones who have symptoms of good bacteria disappearing. The commonest one is usually in females, and they start getting vaginal candidiasis. So if your patient starts having those symptoms or itchiness, then I would initiate probably a probiotic. But again, I don't empirically just cover everyone with a probiotic.
Okay, thank you, Doc. Back still on management, is there a role of misoprostol in management of H. pylori?
That must be off-label use. So I mean, in an education forum, if it's not in the guidelines, I would stay away from it. Yeah, I think that's as much as I would comment, because it's not clear really if it affects or if any effect on Helicobacter pylori. What is known about misoprostol is basically it decreases the risk of having stomach ulcers in patients who are on NSAIDs, including aspirin. But whether I would want to just give a patient misoprostol, I don't think so.
Thank you.
Yeah.
So once a patient has been put on treatment, after how long should you retest for H. pylori?
After you've completed eradication therapy and you've put your patient again on 4 to 6 weeks of PCAB or PPI, I would say go on symptomatology. Are they symptomatic or asymptomatic? Because again, as I mentioned in the initial presentation, remember your antigen test can remain positive even up to 6 months to a year after eradication therapy. So you'll base it on symptomatology of your patients or clients.
Thank you. Then another question is, when you have persistent H. pylori infection and symptoms despite treatment, and the diagnosis was confirmed on OGD and biopsy results, so what would be the next line of treatment or the next steps?
All right, a very good question. Thank you for that. What then that patient requires is a culture sensitivity. So the biopsy, rather than being put in formalin, is put in saline or water for sterile water and sent for culture and sensitivity, because now you need to determine the sensitivity spectrum for that particular infection with H. pylori. So I'd recommend a biopsy, and they send it out for culture sensitivity.
Thank you, Doc. Then what's the role of steroids in ulcerative esophagitis in patients who are H. pylori, who have H. pylori negative gastritis?
Sorry, come again. Role of steroids in ulcerative esophagitis.
Yes.
With H. pylori negative gastritis.
Gastritis.
So, no role of steroids. And two, you'd want to know what that endoscopy shows, because very likely your patient has reflux, and reflux is a whole different disease entity treated differently. There is no role for steroids in ulcerative esophagitis. Yeah.
Then could you comment on H. pylori treatment in pregnant women?
Pregnant women, I think we'd want to ask the gynecologists, but I know, like, for PCABs, the FDA has not commented in terms of efficacy and safety in pregnancy, so it's not recommended. And then remember also the antibiotics and first trimester. Again, there's also caution in terms of that. So it's basically look at the profile, the safety profile in pregnancy for medication. If it is safe in pregnancy, then you would use it. Probably at this point, you'd want to use antibiotics that are safe in pregnancy, more so in the first trimester. I think second and third trimester should not be a concern. The biggest concern is usually the first trimester. But again, I would defer that to our gynecology obstetricians.
Then maybe
collaboration. Yeah.
Sorry. Okay. Then maybe finally, in the emergency situation when you're managing acute gastritis, can you combine a PPA and a PCAB?
So it depends on the emergency situation, because most times, if I get your question right, it is usually pain. Pain is what brings the patient in hospital. If by the time you've given a painkiller and you've injected IV medication, your patient more often than not gets better. Maybe Joanne, you let us know whether you guys are planning to give us an IV preparation for a PCAB, but currently I do not know of any.
No, there's no IV formulation as of yet.
Yes.
Yeah.
Yes. So your standard protocol would apply, but more often than not, your patient with gastritis, the emergency tends to be pain. If it is the other complications of peptic ulcer disease, the algorithms are known. If it's bleeding, you know what the algorithm dictates. If you think your patient is peritonitis, likely due to a perforation, then you also know what the algorithm is.
Thank you, Doc. I think we've actually covered generally most of the questions. So just seeing people saying how insightful the presentation was. Some of the attendees are also asking for your contact and email. Maybe they would want to refer patients to you. But maybe you can just give us your final remarks and maybe your work email in case they need to reach out.
Yeah, sorry, it was on the last presentation of my slide. Let me see. It was on the last presentation, but I'm easily available either on on WhatsApp or SMS. So I'll just post in the chat. My number is straightforward. Email address is Siboy at tarunaconsultancy.com. And the GATS team can always share, and KMA can also share my contacts. I think they have them. So available for any consultations or just to brainstorm.
Thank you, Doc.
Yeah. So thank you very much for the attendance. I think I don't know how many we reached out to. Maybe KMA will give us that information, but I'm seeing we've retained almost 80%, almost 90% of the people who are in from the beginning. So I think my final comment is we need to desist empirical H. pylori treatment without laboratory-backed results. So if it's your stool antigen or if it's your endoscopy, at least let that be your guide to initiate triple therapy. Otherwise, we get a lot of resistance. Number two, always remember your high-risk patient profile, or if your patient just doesn't seem to fit the box or doesn't check the box that this is just simply a bacterial infection, send them over for an endoscopy, because a couple of times we've actually diagnosed patients with gastric malignancies that were being treated as a heartburn or epigastric pain, and we find them with early malignancies. So screening programs, for instance, in Japan are quite effective because they do blanket screening programs. They know they have a high incidence of malignancy. So they do blanket programs and actually do screening endoscopies to diagnose. Because remember, an early gastric cancer will present similarly with dyspepsia or heartburn. So it will be the biopsy that will actually indicate to you that this is a patient who is not your typical patient, and your H. pylori eradication therapy will not simply be enough. So if your patient is simply not getting better and has not had and is endoscopy naive, kindly refer them for endoscopy and biopsy so that they can better be assisted. Thank you.
Thank you, Doc. I think I'll hand over to Kami. Peter, are you there?
Yeah, thank you very much, Dr. for the wonderful presentation. And on behalf of Kenya Medical Association, I want to thank GetZ Pharma for making this webinar a success. I think we'll be sharing the statistics later on. For the attendees, thank you very much. This being our first webinar this year. Hoping to see you attend more of our webinars, which are upcoming, and I'm thinking more partnership with GetZ Pharma as we go on with the year. Dr. Asante Sana for the great presentation. Doctors who provided their registration number while registering, you'll receive your CPD points automatically on your ICPD account. And kwa hayo machache, asanteni sana. Usiku njema wote. Thank you very much.
Thank you. A lovely night. Good night.
Thank you very much.
Bye.
Have a good evening to all. Bye-bye.